Today's topic is HemoSims, a new interactive virtual training simulator for PPH, trauma, and the cardiothoracic setting. And this is a sponsored symposium by LFB and Biopharmaceutical. The chair for today is Dr. Rhona Maclean, who is a consultant haematologist specialising in haemostasis and thrombosis at the Royal Hallamshire Hospital in Sheffield. She is the trust lead in thrombosis prevention and is also director of the Haemophilia and Thrombosis Centre. Her research interests include bleeding and thrombotic disorders and obstetric hematology. So over to you, Rhona.
Thanks, Jo. It's a great delight to be participating in this conference, this virtual meeting. The Thrombosis UK Virtual Conference last year was awarded the World Thrombosis Day Activity of the Year Award, and having attended some of this year's sessions again, I think Jo and the team have done a fantastic job. So thank you for them for organising it and also for arranging such an amazing programme. So as Jo said, I'd like to thank LFB for their generous sponsorship for this session. So it's a great pleasure to introduce Matt Simpson. Matt is he is a consultant anaesthetist in Leeds, which is the second centre in Yorkshire. Sheffield, of course, where I'm based in South Yorkshire, of course, is the best. But he's a lead clinician for both obstetric anaesthesia and for advanced vascular access. He runs the placenta accreta service in Leeds, and he also anaesthetises for the colorectal surgical team and thoracic anaesthesia. He teaches a major obstetric hemorrhage. As a haematologist involved with obstetric haematology, I'm well aware of the challenges of managing major obstetric hemorrhage. A major obstetric hemorrhage continues to be a major cause of maternal morbidity and mortality internationally, with unfortunately suboptimal care contributing to these outcomes. And within other clinical settings, trauma, surgery, cardiothoracic, vascular, major hemorrhagic management is exceptionally challenging. So it's a great pleasure to welcome Matt today to this session to present on HemoSims, which is a new interactive virtual training simulator to assist clinicians in the management of PPH, trauma and cardiothoracics. So over to you, Matt. Thank you.
Thanks, Rhona. So yeah, no, that's great. I'll share the screen and we shall just get that going. So hopefully everyone can kind of see that screen there. That screen is on there for purpose. I'll tell you about that story in a second, but it's great to be here. And as Rhona was saying, there's a lot goes on with major obstetric hemorrhage. I've got into this as I've been lead now at Jimmy's, which is the best part of Yorkshire, for probably about 3 years now, and I've been a consultant for 12 years. I also, as Rhona said, deal with colorectal surgery, and I've picked up the major pelvic exenterations that we do in Leeds, which is exceptionally major surgery, taking everything, prostate, bladder, uterus if it's female, bowel, even sacrum, sciatic nerve, pelvic sidewall. So they are very long procedures, sometimes kind of 18, 20 hours. And more often than that, we're seeing kind of 8 litres, 10 litres blood loss throughout the whole procedure. So I remember one week in particular when we had a placenta accreta, an emergency accreta one day, and I did a pelvic exenteration the next day. I think in that 1 week alone, I gave 72 units of blood and associated products as well with it. So I do see quite a lot of bleeding, not just in obstetrics, but as well as the exenterations. So it's great to give this talk. And one of the biggest things I noticed with all sorts of hemorrhage, not just obstetrics, is that it's the human factors that come into play. It's great that Rhona's here. We have really good links with our haematologists, and I'll show you the algorithm that we use. And one of the reasons we want to talk about the HemoSims project is helping those human factors. So I'll do a little talk, a few little slides to start off with, and then I'll run through what HemoSims can do, and I think how that can help with that MDT approach and the human factors dealing with hemorrhage that can be sometimes rather stressful. So this story was one of our rooms in St James's. It was a lady having a water birth. You can see the pool there, and the emergency buzzer called. I actually wasn't on delivery suite that day, but I always get changed up there. I can kind of use that as my base. So I heard the buzzer as I came up the stairs, walked in, and they were just dragging a very poor lady out of the bath onto that bed there. So I ran in, I ended up looking after the head end and dealing everything. And we eventually got her onto a trolley and into another room. Everything was fine, and she did really well. But this was kind of the aftermath. And one of my colleagues took the photo, and I use it for most of the presentations just to highlight the after effects that we see from kind of major obstetric hemorrhage that can go there. A few facts and figures before we get into the HemoSims. I know we've not got a great amount of time, but I think it's important to kind of set that scene. We all kind of aware of the impact that Rhona was saying as well, and the figures speak for themselves. 800 women die globally per day from preventable causes. The major one of that is hemorrhage. You've obviously got those three at the bottom: hemorrhage, sepsis, and preeclampsia, but still hemorrhage is up there as one of the most preventable causes of maternal mortality. 94% of those deaths, they occur in the low and middle income countries, but that, as I say to my colleagues and registrars that come through, we still have deaths in this country, as you'll see in a second. So although we kind of think it's kind of in a developing world population, it's not. It's still a problem for all of us in Western society as well. So those figures, if we look at the two most important things, the WHO organization and Embrace that produced their reports, the bleeding ones are here. So globally, 27% is kind of the figure to think about. And then in the UK, it's 9%. So that worked out at 20 women in that triennium that actually died from bleeding. And we all know that it is a preventable cause, and that's what makes it all the more sad. So one of the things I do a lot of is training on TEG and getting products in early. There's a lot of emphasis at the minute on getting products on the ward. And just before we were starting this meeting, me and Rhona were chatting about fibrinogen concentrate being now resident on the ward, and that's been fantastic to have, as we'll chat about in a minute. But there's lots of good things that we can do to kind of get there. The reason why the bleeding is so catastrophic, it might seem obvious, but I just want to kind of just put some figures out there to you. Obviously, we're all aware of the physiological changes that associate with pregnancy. But when you look at the numbers in detail, cardiac output goes up by 50%, and that blood flow to the uterus kind of at term gets to about 850 mils per minute. I've just literally about 10 minutes ago had a message from one of my obstetricians that we've got a major placenta accreta that we want to do next week. So we've got to try and fit that in. And actually they were chatting to the radiologists at Sheffield, and the message has come back that this is a big one. It's snakes, not worms. And so we're going to involve the radiologists to put aortic balloons in just in case, because as you can see, 850 mils per minute, there's no amount of squeezing of blood bags using either the Belmont or the level 1 transfuser is going to match that rate. So we physically can't put in at that rate compared to what's kind of coming out. As well as the actual volume of blood that flows through that kind of area of the uterus, you've got the problem with coagulation as well. So blood volume goes up, we all know, by about 45–50%, and you get that physiological anemia because the plasma volume goes up as well. On top of that, there's decreased fibrinolytic activity. So in general, they tend to be hypercoagulopathic, but the minute they start to bleed, all the clotting factors just get used up exceptionally quickly. Also, there's some good things that are coming out in terms of thrombocytopenia, and actually the latest evidence says that 12% of women at term actually meet a diagnosis for thrombocytopenia, so that's platelets less than 150, with about 1% of women reaching a platelet count of less than 100. And that's due to all sorts of causes. There's gestational thrombocytopenia, there's immune thrombocytopenia, and there's obviously the hypertensive disorders of pregnancy. So all of this, as you can see, we've got a large volume of blood that can be kind of hypocoagulopathic. There's anemia, there's clotting factors getting used up. All of it kind of creates the perfect storm for continued blood loss. The other thing as well that I are constantly harking on about to trainees and midwives as well is the fact that these women are often quite exposed. Their temperature drops very, very fast. And as we all know, platelets don't function terribly well when temperature drops. So it's something also to consider, is that kind of that cooling that happens. And it's something we're building into the HemoSims, as I'll chat through in a second. Major reasons for bleeding, we're all aware of the 4 T's. I won't go through them all, but that's the kind of distribution. 70% is due to tone, and roughly 20% is due to trauma. And then the rest is all just kind of the tissue and the thrombin that kind of goes on along with that. So we have to be on it from that tone. And it's that famous quote of, if you hear hoofbeats, think of horses. So if there is, rather than zebras, if you do have bleeding ongoing, the most likely cause is tone. So we should be on that as fast as possible. And something which I see from reading SI reports and looking at critical instances, people just seem to be reluctant to throw pharmacological agents at the problem. They get very focused on kind of the outside things and doing other things, but it's getting the oxytocics in as fast as possible and using a nice, clear, stepwise approach as we go through that. One thing I teach to obstetricians is oxytocin infusion. It won't cause contraction. It will maintain contraction, but it doesn't cause contraction. And it's something that they see in their algorithm as give a bolus and then start the infusion. But there's no point doing that infusion until you actually get that contraction at the start. So we have to be on it in terms of getting that there. There's lots of algorithms out there in terms of major obstetric hemorrhage, and this is the one we use. It's slightly been altered over time, and there's a new one coming through. Unfortunately, it has not been ready for this one, so I didn't want to show you a half-finished one. But the beauty of this was it was written as a multidisciplinary team. So there was myself, there were the hematologists present when we wrote this. We had obstetricians and we had midwives there. So in general, we have some algorithms for what constitutes massive obstetric hemorrhage. We put a call out, and the people that get involved here in Leeds, we have blood bank get that call, obstetric anaesthetist, anaesthetic registrar, delivery coordinator, obstetric registrar, and actually the hematology registrar gets the bleep as well, which we've been doing this for about 3 years, probably 4 now, and it's actually been fantastic because the hematologists are getting involved from the word go. We put the call out for major hemorrhage, and then we give them a number for blood bank to contact us. So we have a dedicated line in theatre, which is different to all the other lines, and blood bank, we have a direct communication with blood bank on that, which again works well. You're not waiting in line, or they're not trying to get hold of you. And then while we are waiting for that major obstetric hemorrhage pack, which is 4 units of blood, 4 of FFP, and 1 pooled dose of platelets, we have fibrinogen concentrate on the ward, which we can make up and we can give while waiting for blood products. Other things that we've done in terms of this pathway is we now have pre-thawed FFP. So down in blood bank, we have 4 units of FFP that are pre-thawed, ready to go. So it's okay, we can get that FFP up within minutes if we want it. And so we've got fibrinogen concentrate and we've got FFP, which we can use for volume and for the clotting products instantly. But in general, the latest audits show that we can get the whole pack within 12 minutes, which is pretty good going from putting the call out. And then on the right, we've got our thromboelastograph. So we use TEG at Jimmy's. I'm well aware there's Rotem as well. You could use either. But we use that to guide our replacement. So in general, we don't tend to do one initially because it will be normal. So our standard practice is to give the whole pack, the fibrinogen concentrate, of which we give 3 grams, and then the 4 blood, 4 FFP dose of platelets. And that's the point I will then start to do a TEG. And based on the results of that and discussion with the hematology registrar, we then guide what we give next. And it's that next step that seems to be the tricky bit for a lot of people. Everyone can give all the first pack when it arrives, but if there's ongoing bleeding, or the blood's just not clotting, it's a little bit oozy, what do you give next? And that's where the bedside tests and the experience of the hematologists come in. And sometimes that changes based on the clinical situation and on the TEG results. So sometimes we might give more of FP, sometimes we might give another dose of fibrinogen, and it's just an ongoing discussion and communication between the teams. And that's something that I want to get across. If you want to get one thing across from this, for me, it has to be a multidisciplinary approach to managing major obstetric hemorrhage. You can't do this alone, even though a lot of places do and go about it. We certainly don't here, and we're a very big unit doing all the accretors and the cesarean hysterectomies that come through, but we involve everybody. It's a definite team approach, and we built this algorithm with the team, and we're continuing to edit that. So I couldn't do this alone. One of the big reasons why we changed it and did this was with that fibrinogen concentrate. So there's lots of studies out there now. This was the one that we used at the time to bring it in. It was a nationwide retrospective study that was measuring blood loss and measuring things like full blood count, hemoglobin, APTT, fibrinogen. And you can see that graph on the right, that a blood loss of 0 to 1 litre, you've already got that drop in fibrinogen. By 1 to 1.5 litres, you've got another drop, and it just keeps going down. And the results of this show that about 1 litre of blood loss, roughly 5% of people will have a fibrinogen less than that magic number of 2 grams per decilitre. By the time you get to 2 litres blood loss, about 20% have got fibrinogen less than 2 grams per decilitre. And the reason for that is off to the right there. You have actual fibrinogen loss. You also have the dilutional factors because people are giving fluids. I mean, I call crystalloids, the registrars and trainees with me laugh because I don't call them crystalloids. I call them non-clottable, non-oxygen carrying fluids because that's essentially what they are. They're not adding to help in any way. And you also get this consumptive loss, which massively accelerates the problem. So we do lose fibrinogen quite rapidly. And we found that by replacing it quickly and having something to give while you're waiting for those blood products to arrive has made a huge difference. And our latest audits that we get monthly from Blood Bank since we started doing this, and I say it was about 4 years ago now, was we are decreased the amount of blood products that we are giving for definite. So really good study. There's been lots of other studies that have come out since to show the value of kind of giving fibrinogen early. And purely from a personal perspective, and I hear it from my colleagues as well, you actually feel like you are doing something valuable as opposed to just pouring in non-clottable, non-oxygen carrying fluids and volume while desperately waiting for that porter to arrive with the blood products. You've got concentrate that you can make up and you can give to that patient, and the surgeons will tell as well that it actually does make a bit of a difference. So just a few bits about postpartum. This was one of our latest accretors, the picture on the right. This was post-delivery, so we did an upper segment cesarean section, and you can clearly see the placenta there and those big chunky vessels that are eroding through. So great picture that we saw, and this ended up, we tend to do cesarean hysterectomies in Leeds for these. When they get picked up, they come through planned cesarean hysterectomy. So we do upper segment cesarean section, leave the placenta in situ, and then do an en bloc hysterectomy. Don't try and touch that placenta at all, because there's no way on earth you're going to get that placenta out without catastrophic bleeding. Reason why we're potentially seeing more of these, we are doing more cesarean sections, it's quite topical, is that since our Cundun report came out about national the percentage of cesarean sections nationally, we are going to see more of those now that maternal request is sufficient grounds to have cesarean section. So we're certainly seeing more placenta accreta syndrome. I'm always exceptionally wary of retained placentas. It's something that I kind of hark on about when I'm teaching and training, is a lot of people just think, oh, just take the placenta won't come, take that to theatre. I would always argue that you should ask the question, why is that placenta not coming? There is a reason why that placenta is not coming. And you'll find in quite a lot of cases that it's some form of accreta that's kind of stuck there. And then lo and behold, the placenta comes and you just get quite profound blood loss. Also, in terms of the retained placentas, they don't tend to be given priority for theatre. And I've got numerous serious incidents and case reports that I read where the manual removals have just been sat on the ward for a while waiting for a slot because it's deemed non-urgent. And those are possibly the worst ones in my experience, because they just have a constant slow trickle of bleeding, which then becomes this consumptive. It uses up the blood products, and they end up coming to theatre already pretty depleted, and then the placenta's removed, and lo and behold, we're starting not from kind of normality in terms of clotting profile, but we're already at that consumptive loss. So I'm always very wary about retained placentas, and I pass that on to the trainees that actually just be ready. Just be ready. Most of the time they'll be fine, but you will get the odd one that won't be, and those are the ones that can really catch you out. So a little bit about kind of this kind of human factors that I've been mentioning about, and things happen. So we've got clinicians that are busy treating the critically ill patient. There's often multiple phone calls going to blood bank, going to colleagues for extra hand, going to hematologist. There's multiple people present. So there's usually a lot of people in theatre by the time you have a major obstetric hemorrhage. And previously there was lots of confusing requests. We had lots of different packs in Leeds, and there was pack 1 and there was pack 2 and there was an obstetric pack and there was this. And one of the biggest things that I did when we took over was actually, let's just have one pack. And I think most places are similar to that. And if you don't, I'd encourage you to do that. It just avoids that confusion of, okay, who's getting what? It's just very, very simple. But then from the other side of things, and I'm sure Rhona can answer a question about this from that side, is blood bank. They're isolated from that clinical area. So they are removed from that patient. So they don't have that awareness of the urgency and how quick things are going, and they've got very strict protocols, rightly so, and lab procedures they've got to follow. And one of the things we've done is try to kind of speed that process up a little bit. So as well as blood bank getting the arrest call and the hematology reg getting through to us, what the blood bank do is when that call goes off, somebody is then allocated purely to deal with the requests for kind of obstetrics. And we've done it as well, not for obstetrics, just for major hemorrhage in theatres as well, for like the exenterations that we do. And that's been fantastic. You have one person who you can get the name of, and you can have that constant communication throughout with there. Okay, so I've hopefully kind of set the scene. You could speak for hours and hours and hours about major obstetric hemorrhage, and I didn't really want to do that. I wanted the focus to be a lot more about kind of how we can help people and train people to kind of deal with these things. So I'm going to give you a very brief introduction to HemoSims. It's still a work in progress, and currently we've only got a French version, which makes things a little bit interesting. We're translating everything through to English, and we're adding to it all the time. So I'm gonna have to stop sharing the screen and I'll load it up. So if I just bear with me for 1 second. Okay. What's happening here? Excuse me for 1 second. I just need to click that. Right. Okay. So if I share this screen here, hopefully you can see a door in front of you that's kind of getting us in here. So when we go into it, there's a few little tutorials to go through. I will click through this very quickly. The main aim of HemoSims is to work as alongside a kind of training package in hemorrhage. And I'll just get through this little bit here. Okay, so this is the kind of basic mode that we've got. And what we're trying to do is make things as realistic as possible. We all know there's good evidence that simulation works, but we try and do regular real life simulations on labor ward. We try and do one a month of running drills. It's quite labor intensive, and if labor ward's busy, it's quite hard to do. So what this is designed for is to try and do a classroom based approach to simulation. But whereas other simulators kind of, you would say things like, okay, let's just put an IV axis in, and the IV axis is in. What this does is it keeps a clock. So there's a time associated with putting IV axis in. There's a time associated with requesting bloods, and it builds it in to the program. So you've got this clock here, and we can advance that time as much as we want to while we're waiting for bloods, say. And what will happen is, as we look around, I'll bring a patient into this room in a second, but what I want to do is just show you the actual room. So we can access the phone, we can phone people, we can go and we can wash our hands. Up here we have our epidural, and we have our monitor here that we can turn on and see what's going on. And as we move around the room, you have a drug cart that's here. So let's bring a little patient in, and I will show you a few bits that we can do at the minute. Again, I'm not planning to run through a whole simulation here, but it's more just to give you a flavour of what we're producing at the minute and how this can be helpful. So again, we're trying to make it as realistic as possible. So here's our patient, and if we try and do something to the patient and it's painful, she will tell us. She will tell us that's painful. So here we go. We have a midwife that's with us here. What's always good when you're in a situation like this is to get some kind of reinforcement. So bring another nurse into the room. So there's plenty of us here. And currently we're in the eyes of the anaesthetist. So we are here. If I look down, you can see our shoes just about there. Here we go. So there's our patient. So first of all, we should probably put the monitor on. So we'll click that monitor and we'll turn the monitor on. And what that does is it gives us our observations, and in the bottom left of the screen, all the way through, we have our observations. And we thought, rather than have to constantly look back at the screen to see the observations, in real life, it's usually just a quick glance where you can hear the beat going along. So that they're always visible, are the observations there. We have our obstetrician down at the bottom here. So he will do anything we want to do with him and ask him to do things there. So in terms of things that we can do, why don't we just kind of start some uterine massage? That would be quite useful to do. So the midwife is just doing some uterine massage, and as you can see, our lady says that's rather painful. So for things like this, what we might want to do is actually give some pain relief. So let's go up and we'll give a little bolus down the epidural as a start. So let's give a little bolus down there, and we'll give some bupivacaine, and we'll give 10 mils of that. And we can get that working as we're going along. To just try and get some pain relief on board. So we could administer that there. So that's our little epidural bolus going. We might want to give some other pain relief. So we could go to our drug trolley here, and we could administer medicines. And what this does, it will give us a whole long list of medicines that's going down there. And you can see at the top, tranexamic acid. That's something that kind of everyone kind of reaches for straight off. So let's give that into a vein. We'll give that as a bolus, and we'll give the 1 gram as that, just to get that working, and we'll administer that there. And the idea behind this is that actually this will add time to the clock, because it does take time to administer things. So we're trying, as you can see, to make this as realistic as possible. And all this time that we're not doing anything to kind of stop that bleeding, there is constant blood loss going on. And that will change this lady's parameters. So if we did nothing, you'll see the heart rate constantly rising, you'll see the blood pressure eventually starting to fall, you'll see saturation starting to fall as we go along there. So we should probably have a little look and see if we can start to kind of see what we can do. So this scenario, there's a couple of scenarios here. This is a lady that's got a retained placenta. So we can have a little check of the tone of the uterus. We can try to deliver that uterus, so just do some controlled cord traction, and lo and behold, it's painful. We haven't currently gotten control of the pain relief, and rightly so, because all we've done is given a bolus which won't work instantly. And as with all these things, it's not going to be such a simple thing as the placenta just coming away with controlled cord traction. So we can move around. We can ask the nurse that's come in, probably at this point, to either put some oxygen on the patient. Again, so we can do that. We'll go with 6 litres. Why not? For now, we can do that, and we can put some oxygen on. So you can see we're trying to involve all the members of the team, and that's one of the beauties of this program, is that we have to kind of think about who would do what. And I can envisage us doing this in a classroom, almost like prompt training. You've got all the members of the team there. Okay, what should we do next? Okay, well, let's ask the midwife to verify the tone, and maybe let's kind of think about putting. Let's put a collection sac in so we can actually start to measure blood loss, and we can see how things are going. As with all anaesthetists, it's usually quite good if we get a second drip at this point. So again, we can come in here and we can reassure the patient or the father and go along there. So there's lots of things that we can do. Apologies that it's in French for those that don't speak French. My French is not great, I have to admit, so I'm working with a team in translation to go through.
Matt, we're just we're just after 5 there. So
yeah, I'll stop there because I'm sure there's quite a few questions coming through. Yeah. I just wanted to give a bit of a flavour of the programme, and hopefully you can see. I can envisage us using this for that kind of training programme. One thing that it does, just to finish off before we go to questions, is at the end, it gives a bit of a score, and it logs the time of when we did things. So it will log when the second drip was given, it will log when the oxygen was given, and we can then give a score based on their performance of how they've managed to with that. Okay, I'll shut up for now. Thanks for listening, and I'm happy to take any questions that have kind of come through.
Matt, thank you. That was a fantastic presentation. From my perspective as a haematologist, it is really informative and useful to see the anaesthetist perspective. Just as you said, I see the blood bank perspective and the phone calls I get. And I can definitely see the utility of this. I've got a couple of questions. I'm not sure if anybody else has asked a question yet. So whilst we're to give people a chance to think, I thought that scoring bit at the end, just to start with that with a minute, it was really helpful. Does anybody look in a standardized fashion at current obstetric hemorrhages about what time things happen? So at what time does the call for major obstetric hemorrhage start? At what time is the tranexamic acid given? What time is blood bank contacted? What you do have the time when products arrive, but are the scores within HemoSims the same things that you capture during a major obstetric hemorrhage event?
Yeah, to some degree. So generally speaking, one of the things that we've started to do, and I'll hold my hand up, we're not amazing at it, and some people are better than others, but whenever there is a major hemorrhage, either in theatre or on the ward, one of the things that I try my best to do is allocate someone to be a scribe, and their only job is to scribe. And what we do is make it very clear who in the room is scribing. So I would walk in and say, okay, you are going to be the scribe. And then whenever anything happens, we direct that information to the scribe to keep track of those times. The reason for doing this was a lot of SIs that come through from HSIB investigations. It's all timelined. So everything does get timelined when you look at these kind of things. And I get given anesthetic charts to look at, and I get given reports, and more often than not, it's like, okay, well, it would have been, with hindsight's a great thing, and it's like, okay, well, I think it would have been better if they'd have got a second drip a little bit earlier, because you could see that they were struggling to get enough volume in through that drip, as well as the oxytocics at the same time. Or it would have been better if they'd have put a major hemorrhage call out earlier. And that's one of the biggest things that I see, is people are reluctant to put that call out. You often see people phoning blood bank and requesting 2 units of blood, and then phoning back 10 minutes later and requesting some FFP, and then 10 minutes later they put a call out, and it's like, okay, 20 minutes ago was the time to put that call out. And I don't know why there is always seems to be a reluctance to just go, we have a major hemorrhage here. Even if it's the early stages, it's fine to put that call out, because I think from a blood perspective, it's better that you can just get everything ready, and then we can just stand you down, than it is to do it in a piecemeal approach and just give us bits there. So yeah, I think the reason is we try and just look back and go, this is not the gold standard, but this is how it should be approached to get everything in the right order. Yeah.
Claire McClintock in New Zealand talks very eloquently about I think some of the training that they did, and I think it is incredibly difficult to do this training, to find the time and to get people together to do it, about the difficulty of actually identifying what a major obstetric hemorrhage is. So how much this collection of blood, how much is that actually? What does a litre look like? What does a litre and a half look like? And we're rubbish at, well, I particularly think I'm very poor at actually, and luckily that's not my job, but actually identifying what does a major obstetric hemorrhage look like on the bed sheets or in the bed.
Yeah, no, completely agree. I mean, there's hundreds of studies that show that clinicians are useless at quantifying blood loss. Even when we start to kind of measure them in theatre or wash the swabs, it's always an estimate, and most kind of studies and things always come up with the same result, that people underestimate blood loss. Definitely.
When you're using HemoSims, sorry, I don't think we've got any other questions yet, so we'll give me the opportunity just to carry on. But if you have, do you anticipate this to be used in a web-like fashion? So you could have your midwife on one computer and your porter on or your I don't know, theatre orderly in one place, and then the consultant needs to be there, and your obstetrician somewhere else, and somewhere else. Are you anticipating having people in different terminals and doing different things, but on the one simulation? So and does it lock you out from certain actions? I mean, how does it work?
No, not necessarily. And I've had this discussion with the developers as well, and I think it can be used in lots of ways. One is to build in one big room, everyone there, and running through it together. Okay, what should we do as a team next? Another option, which I think would be useful, is to let people log on and do it in their own time. And then when the score comes through, I get sent the report. And it's like, okay, so then I meet up with that person afterwards and go, okay, let's talk through how you did, almost like a test. It's one way of doing it. So it can be part of the induction program onto labour ward for anaesthetists, for obstetricians, and they get a score which comes to me. And then as long as it's used appropriately and you have that follow-up meeting afterwards, okay, let's talk through, why did you do this before this, or what made you give that drug rather than this drug? I think that has a really good benefit. Or like you said, over a web-based thing, just like we've done today, really, somebody can drive it, and you can have that discussion. So I think it's going to be pretty versatile, for definite. Yeah.
We've used Lifesavers, the Lifesavers resuscitation CPR online module within our trust for some of our CPR training and maintaining our competency. And it again is, I mean, it's videos. I don't know if you've seen it. It's videos of some. There's one where somebody chokes and somebody else where somebody has a cardiac arrest, and it flashes up on the screen. So what would you like to do now? And then you've got to do your CPR at the right rate. So make sure you press your fingers at the right rate to do your CPR. But I did that actually with some of my to maintain my competency with some of my registrars last year, which was slightly embarrassing. But I did remember when to use atropine, which was great. But the great thing about it was that the thing that was striking to me was that it was beneficial for us all to do it as a group, and one person might have been doing the driving, but the whole group got involved. And I think the learning we took from that was very useful. So this is similar in a variety of ways. So I think it is a really exciting proposal.
Yeah, and again, something that a little passion of mine is getting people to appreciate other people's roles. So one of the things that I do a lot of training of the midwives and obstetricians and teach on MOE and POMP, and it's what you sometimes have to do is go, okay, I know you're an obstetrician, but today on this simulation, you're going to be the anaesthetist. And you as an anaesthetist, you're going to be the obstetrician. And let's try and have a bit more appreciation of everyone's role, which helps when it comes to big situations like this. And one thing that the obstetricians always say is, look, I often feel a little bit helpless when this is happening. What can I do to help? And it's like, well, there's lots of things you can do. You can man the phone and be in discussion with a hematologist. You can be there, and you can help us. You can ask if we can put another drip in. You can ask if you want to do this. And there's lots of skills that obstetricians and midwives have that are all transferable to come across. And you only pick those up when you have appreciation for what's needed.
And when you look at, again, it comes back to the air industry again, isn't it? The air industry is much in advance of the healthcare with regards to simulations and what to do when things go wrong. And we've got a lot to learn, I think, from them in that sense. So I think, I know simulations are much more widely used in training for junior doctors, for example, but not so maybe so widely once we're established in the healthcare setting. So I think this is a great, it's a really exciting development.
Yeah,
so
I'm very excited by it. I think it's been very interesting so far. Obviously, trying to plan what happens if nothing happens to that lady, and the rate of blood loss. And as I mentioned at the start, big little bugbears of mine is temperature. So we've built in the fact that if you don't cover them up or you don't put a warm blanket on, the temperature will drop, which will increase the rate of bleeding. Yeah. So we're trying to make it as realistic as possible, but keep it timely, which is realistic. So as the clock goes on, you're not suddenly going to request blood and it's going to arrive through the door. As we request blood, there's a little timer that says like 20 minutes till that blood arrives. So you've got to just watch things happen, and you've actually got to do things in that 20 minutes, which you have to do in real life. You can't just magically, with a lot of simulation, oh, you've ordered the blood and here it is. It doesn't work that way in HemoSims. We've made it as realistic as possible.
So when do you think it might be available to other, obviously it's in development. Is there a plan to make it available?
Yeah, it's in development at the minute. I think the current aim is working towards kind of a working version that's fully in English. We're doing it in lots of different languages. It's currently kind of nearly there in French, and we're converting that to English, but there will be other languages as well. So we're looking at October at the minute.
Fantastic.
There's a first test date, and then hopefully by the start of next year, it'll be ready to go for everybody.
So I'd like to thank again Thrombosis UK and Joe for extraordinarily fantastic meeting. It's a great pleasure to be part of that, and to LFP for their sponsorship for this session, and to Matt for his wonderful presentation. So, and also to all you that have joined us and spent your time today participating and listening. So thank you very much.